topic for my today's discussion is ankle instability, focusing on ligamentous injuries. And we will assess the role of stress radiographs and dynamic USG, and we will also see when MRI is needed. So, first question that arises in our mind is what leads to ankle instability? So, when we talk about ankle is the most frequently injured major joint in the body. And when we talk about ankle, lateral compartment is the most commonly affected side because there is natural tendency for the ankle to undergo sprain in the inversion and plantar flexion. And in that position, that is the lateral compartment which is most often affected. 20% of the acute ankle sprain patients develop chronic ankle instability. And the failure of functional rehab after acute ankle sprain leads to the development of chronic ankle instability. Unlike acute ankle sprain, chronic ankle stability might require surgical intervention. So we need to assess these disease and these conditions very accurately. So what is chronic ankle instability? Chronic ankle instability denotes the occurrence of repetitive bouts of lateral ankle instability resulting in numerous ankle sprains. And it has two components. So what are these two components? Functional instability and mechanical instability. So when we talk about the mechanical instability, it is induced by ligament laxity, while functional ankle instability is caused by postural control deficits, neuromuscular deficits, muscle weakness, and proprioceptive deficits. Functional ankle instability is usually treated non-operatively, whereas mechanical ankle instability is caused by defective ligaments and bony structures, and it is repaired by, and it undergoes surgery with repair and reconstruction. This is a diagram which shows the entire umbrella term chronic ankle instability, which comprises of both functional and mechanical insufficiency. And in most of the cases you see a component of mechanical as well as functional component both. So majority of cases we might find component of mechanical as well as functional instability. So what comes under mechanical insufficiency? You can have pathological laxity. There can be arthrokinematic restrictions, degenerative changes, synovial changes. And in functional insufficiency, the patient may have impaired proprioception, impaired neuromuscular control, strength deficits, and impaired postural control. This is the diagram which shows different types of ankle movements. So before we proceed further with the topic, we should know what is which movement. So this is the neutral position of the foot. This is eversion and this is inversion. This is again neutral position. This is dorsiflexion and this is plantar flexion. And when the foot undergoes medial rotation, this is adduction, and when it undergoes outside rotation, this is abduction. So what are the structures which are responsible for ankle stability? So the ankle complex, it comprises of three articulation. First is the tibio-talar and the articulation between the talus and the tibia and fibula. Then we have subtalar articulation where talus articulates with the calcaneum and navicular bone. And then we have this inferior tibio-fibular joint. So all these three major joints, they comprises and they are responsible for the stability of ankle joint. And there are three major contributors to the stability of ankle joint. First is the congruity of the articular surface. So articular congruity is very important. Then second is the ligamentous restraint. So intact ligaments are very important for providing stability to the ankle joint. Then we have musculotendinous units which allow for dynamic stabilization of the joints. So now when we are talking about the ligaments, we should know what are the different ligaments around the ankle joint and what in which direction they go, to which bones they attach. It is quite simple. The names are based on the bony attachment. So first we'll start with the tibiofibular ligament. So anterior tibiofibular ligament, it goes from the tibia to the fibula, and similarly we have the posterior tibiofibular ligament. So both these ligaments, they provide stability to the inferior tibiofibular joint or syndesmosis. Then we have anterior talofibular ligament. So here we can see, as the name indicates, it goes from talus to fibula. Here we can see it goes like this, from talus to fibula. Anterior talofibular ligament. It is located anteriorly. It attaches talus to the fibula. And it is the weakest and most frequently injured ligament. It blends with some fibers of the capsule of the talofibular joint and tibiotalar joint, and the anterior talofibular ligament, it serves to stabilize the talus and it prevents anterior talar motion, and it is most frequently injured ligament. Then the second ligament that forms a part of lateral ligamentous complex is posterior talofibular ligament. So as the name indicates, it is again going from talus to the fibula, and it is located posteriorly. It is the deepest ligament in the lateral ligamentous complex. It is intracapsular but extrasynovial. Primary function is to counteract the posterior displacement of the talus, and it is under greatest strain in the full dorsiflexion of the ankle. It is rarely torn because bony stability protects the ligament when the ankle is in dorsiflexion. So this ligament is rarely ruptured. The third ligament is the calcaneofibular ligament. As the name indicates, this ligament goes from the fibula to the calcaneus bone. Here we can see it goes like this. It is closely related to the peroneal tendons, which lie just above this ligament. So it is the longest ligament in the LCL complex. It extends from the tip of lateral malleolus to the trochlear eminence on the lateral surface of calcaneus, and it is a stabilizer of the subtalar joint. It functions to restrain the inversion of the calcaneus and with respect to fibula. And in inversion strain, it is usually sequentially torn after the anterior talofibular ligament. So first the anterior talofibular ligament will go, then calcaneofibular ligament will go. So isolated injury of calcaneofibular ligament is not seen. Now coming to the medial ligamentous complex, or what we call as deltoid ligamentous complex. It consists of two layers, deep and superficial. So in deep layer we have anterior and posterior talotibial ligament. So as the name indicates, it goes from tibia to the talus, anterior and posterior tibio-talar ligament. And superficial ligament consists of tibio-navicular ligament, tibio-calcaneal ligament, and here we have a spring ligament which goes from calcaneus to the navicular bone, and the third component of the superficial component, it goes to the spring ligament. So that is tibio-spring ligament. And deep layer is stronger and more important for the ankle stability than the superficial layer. Lesions of the deltoid ligament occur during severe eversion injuries and are usually associated with fractures of the lateral malleolus and with the lateral displacement of the talus. Rupture of the deltoid ligament is rarely encountered without additional injuries to the ankle, owing to the uncommon occurrence of eversion ankle sprain and to the intrinsic thickness of the ligament. So the ligament is very thick and eversion injuries are quite rare. So deltoid injuries are generally seen only when the ankle undergoes severe trauma. Now coming to the imaging evaluation of the ankle joint. First we'll talk about the radiography with a special focus on the stress radiography. So when we talk about ankle radiography, we have two types of projections, basic projections and stress radiographs. So in basic projections, we have anteroposterior view, especially mortise projection, and second is the lateral view. In stress radiograph, we will talk about both lateral stress radiograph and medial stress radiograph. So this is the AP radiograph of the ankle, this is mortise projection, and this is lateral projection. So how mortise projection is different from the AP view? In this we can see both the lateral malleolus and the medial malleolus are in profile, and the uniformity of mortise joint should be seen without any superimposition from any of the malleolus. And we should also be able to see the base of the fifth metatarsal. It is because when patient undergoes inversion sprain, peroneus brevis tendon which attaches over here, it can lead to evergent fracture of the base of fifth metatarsal. Now let's move to the stress radiograph. So again, as I have already pointed out, we will discuss the stress radiograph in two parts. First is the lateral and second is the medial stress radiograph. In lateral stress radiograph, we have anteroposterior projection with inversion stress. So as we can see, patient is provided mechanical stress in the inversion direction, whereas also known as varus stress radiograph. And second is the anterior drawer stress radiograph, in which we provide pressure over the leg, and then we take a lateral radiograph. So anteroposterior stress radiograph demonstrate widening of the joint space if there is lateral ankle instability. So this joint space is going to get widened, and in the anterior drawer stress radiograph, if the anterior talofibular ligament is torn, it will lead to anterior talar subluxation. So how do we assess these radiographs? So the radiographic criteria for chronic lateral ankle instability surgery are more than 15 degree. So either it should be more than 15 degree or side to side difference of more than 10 degree. Tibio-talar tilt angle. So this is talus and this is tibia, and this is tibio-talar tilt angle. If it is more than 15 degree or if the side to side difference is more than 10 degree, then we can say that this patient is having chronic lateral ankle instability. And in this anterior drawer stress radiograph, if this distance anterior, because talus undergoes anterior translation or subluxation, and this distance increases, and if it is more than 10 mm, or if the side to side difference is more than 3 mm, then there is anterior talar translation. So the clinical judgment for chronic ankle instability based on ankle stress radiograph, it requires the images to be consistent and reliable. So the radiograph need to be taken technically sound. Now moving to the medial stress radiograph, here we have mechanical stress view, and another one is the gravity assisted stress radiograph. In this we provide stress over the deltoid ligament complex, and if the deltoid ligament complex are torn and there is insufficiency over the medial side, this joint space is going to increase. But commonly we see lateral ankle instability because the most common mechanism of ankle sprain is inversion and plantar flexion. Now let's move to the ultrasonography of the ankle with the special stress on the dynamic ultrasound. So as we can see in this image, so this is the position of the patient's foot, and this is how we keep our probe, and this is the static ultrasound image which shows the lower end of fibula. This is the talus, and this is the anterior talofibular ligament, which is very important ligament and most frequently injured ligament. And here we can see this is the articular cartilage that covers the talus, and here we can see slight amount of joint fluid that is present in the ankle joint. So anatomical bony landmarks are very important, and ultrasound probes should be aligned according to the anatomical bony landmarks along the course of ligament, and they are generally scanned along their long axis. This is the dynamic image showing the anterior talofibular ligament. So when we ask the patient to do inversion, this ligament undergoes a stress. So if there is any partial thickness tear or even full thickness tear, it leads to widening of this space, and the fluid go inside the torn edges. This is the patient with complete ATFL tear, and here we can see There is joint fluid which is going in the torn margins and the ligament is completely torn, and with patient's movement this space is getting widened. Second important ligament is the calcaneofibular ligament. This is the position where we take the calcaneofibular ligament. So here we can see it is like a hammock, and these are the peroneal longus and peroneus brevis tendons. So when we do dorsiflexion in this ligament undergoes stress and it leads to a movement of the peroneal tendon. So if this movement is present, it indicates that the ligament is intact. Now let us see a pathological case. So this is a young patient who underwent ankle sprain, and here as we can see there is lot of edema in the subcutaneous plane, there is lot of hyperintensity, and there is fluid in the intermuscular facial planes and in the subcutaneous areas. And as we move down, we can see here at the expected site of attachment of the anterior talofibular ligament, there is no such ligament, so ligament is torn. So there is complete tear of the anterior talofibular ligament. There is leakage of the joint fluid into the surrounding tissue, and here we can see this is the posterior talofibular ligament. It is intact but it is slightly hyperintense, and the calcaneofibular ligament is also showing hyperintensity. So there must be some kind of sprain that is involving the calcaneofibular ligament, but the anterior talofibular ligament is completely torn. Now let us see the medial ligamentous complex. So here we can see normally there should not be much hyperintensity over here, but here we can see there is some lot of hyperintensity deep to the medial tendons, and so there is a sprain in the medial or deltoid ligamentous complex. This is another patient who underwent trauma to the ankle joint, and here we can see a fracture line which is involving the medial malleolus. So there is a fracture, transverse fracture over the medial malleolus, and there is lot of hyperintensity over the medial ligamentous complex. So these are actually not intact, and there is lot of subcutaneous edema. Let us see the axial plane. So as we go from cranial to caudal, we can see the anterior inferior tibiofibular ligament is torn, and there is widening of the space between the two bones. So there is a rupture of the syndesmosis. There is fracture that we have already seen in the coronal plane. So this fracture is also seen here in the medial malleolus. As we go down, we can see the anterior talofibular ligament is intact. Posterior talofibular ligament is also intact, and the deltoid ligamentous complex is showing hyperintensity which suggests sprain. This is another case of ankle sprain. So again we will scroll from cranial to caudal. So here we can see again there is complete tear of the anterior talofibular ligament. So as we can see here, complete tear of the anterior talofibular ligament. Posterior talofibular ligament is intact. Calcaneofibular ligament is also intact. But here we can see on the medial side the ligaments which are deep to the tibialis posterior and flexor digitorum longus. The medial ligamentous complex is showing homogeneous heterogeneous hyperintense signal on the speedy facet sequence, and there is complete loss of the normal ligamentous signal intensity over here. So there is tear over the deltoid ligament. Now, coming back to the topic, let us see the lesions which are associated with chronic ankle instability. So, the first is chronic regional pain syndrome. You can see neuropraxia, sinus tarsi syndrome, tendon disorders like peroneal tendinopathy, dislocation and subluxation. You can have impingement syndromes. Then there can be fractures such as anterior calcaneal process fracture, fibular fracture, or fracture of the lateral talar process, or you can have loose bodies. Patient can have osteochondral lesion of the talar dome or distal tibia. So majority of these lesions can be evaluated with the help of imaging. Some can be evaluated with the help of both ultrasound and MRI, and for some lesions you need to have MRI. Now let us see the point-to-point difference between stress radiography and dynamic ultrasound. So what are the pros and cons associated with both the imaging modalities? So the pros or benefits that we have with the stress radiography are patient compliance and cost. It is easily available and patient generally tolerate well. And the ligamentous function to maintain the joint stability can be evaluated directly with the help of stress radiography. Similarly, with dynamic ultrasound, also patient compliance is good and cost is also less. And again, we can see some ligamentous rupture on ultrasound very well, like anterior talofibular ligament, calcaneofibular ligament. So all these ligaments which are easily accessible through ultrasound can be evaluated, tear can be seen, and if there is any tear, you can do dynamic ultrasound and see whether there is any widening of the space or not. Then the cons which are associated with stress radiography are that the whatever data we have, published data regarding the talar tilt and the anterior talar displacement stress radiography, they are too variable to determine the accepted normal values compared with the injured values, and so it is difficult to say what value is abnormal and what value is within the normal range. Then the criteria for surgical indication or cutoff values are also variable. Cons which are associated with dynamic ultrasound is that it requires long training curve and not all ligaments are very easily visualized in ultrasound. Then comparison with MRI of both the imaging modalities. So stress radiography is more valuable than our MRI scans in examining the mechanical component of chronic lateral ankle instability. But obviously we can't directly visualize the ligament. We can only see the indirect signs of the instability, and it has high specificity but low sensitivity. So if it is present, then we can say that there is instability, but if the patient is having instability, it is not necessary that we get all the imaging appearance on the stress radiography. Then on dynamic ultrasound, it has higher spatial resolution, so even partial fiber rupture can be seen on ultrasound better than MRI. But deltoid ligament pathologies are difficult to evaluate on USG, and so in that way MRI is better. Take home message. So differentiation between functional and anatomical ankle instability is very essential to guide the proper treatment. The surgical and conservative management options can be very much developed by the in-depth knowledge of the ankle anatomy, biomechanics, and pathology. All the imaging modalities have their advantages and disadvantages, so make use of the available resources wisely. Thank you.